All right, the injured wrist. We see it all the time in the ED, right? But here's the thing. Are you really confident you're not missing those subtle, sneaky injuries that can cause a lifetime of problems? In this explainer, we're going to break down a systematic approach so you can catch them every single time. Okay, let this number sink in for a second. 25%. That's 1 in 4. A staggering number of serious carpal injuries are completely missed when the patient first comes in. And look, we're not talking about a minor oops here. Missing these can be absolutely devastating for our patients. Think avascular necrosis, chronic instability, crippling arthritis. The stakes are incredibly high.
So here is how we're going to tackle this. We'll start with the high-stakes nature of these injuries, cover the essential anatomy, walk through the hands-on exam, decode the x-rays, and then hit the critical diagnoses and complications. Let's get into it.
Right, section 1, the high-stakes wrist injury. And it all starts with that classic story, right? The foosh, a fall on an outstretched hand. Sounds simple, but don't be fooled. That one mechanism can cause everything from a straightforward distal radius fracture to a really complex and very easy to miss carpal dislocation.
So here's a great clinical pearl right off the bat. The patient's age should immediately start shaping your differential. If a young adult comes in after a foosh, your brain should be screaming carpal bones, carpal bones. But for your pediatric patients or older adults, you're going to be thinking more about a distal radius fracture. It's a really useful pattern to keep in mind.
Okay, let's talk anatomy. And don't worry, I promise this isn't going to be a death by PowerPoint anatomy lecture. We're just going to zero in on the structures that are most at risk, the ones you absolutely cannot ignore. First up, the scaphoid. And this little bone has a serious design flaw, a real Achilles heel. Its blood supply is, well, it's terrible. It's retrograde, meaning it flows backwards from the distal end to the proximal end. So about 70 to 80% of the bone, including the whole proximal part, relies on these tiny little vessels that enter right at its waist. And you can see where this is going, right? A simple fracture right through that scaphoid waist can act like a pair of scissors, just snipping that delicate blood supply. And if you miss that fracture, the proximal fragment is starved of blood. It dies. That's avascular necrosis, and it's a disaster. Next, we have to talk about what's often called the forgotten joint of the wrist, the DRUJ, or distal radial ulnar joint. This is what lets you pronate and supinate, turn a key in a lock or open a doorknob. It gets injured a lot with distal radius fractures, but it's so easy to overlook, and missing it is just a setup for chronic pain and a major loss of function. We'll definitely come back to how to spot this on exam. Okay, time for the hands-on examination. And honestly, this is where you can be a diagnostic superstar. Before you even think about ordering an x-ray, your hands can often tell you exactly what's going on. Let's walk through a system that finds a diagnosis before the film even comes back. So I want you to think of the back of the wrist as having 4 key divots you need to check every time. Start by finding Lister's tubercle on the radius, and just distal to that, you'll find the scapholunate space. Then pop over to the ulnar side, just distal to the ulnar styloid for the trichetrum. Then, of course, the famous anatomical snuffbox. Make sure you get the patient to ulnar deviate their wrist. It makes the scaphoid pop right out for you. And finally, that little divot between the radius and ulna. That's your DRUJ. Now let's flip the wrist over to the volar side. Here, you're hunting for 3 bony bumps. First, the scaphoid tubercle right at the base of the thenar eminence. Tenderness here is a big deal. Then the pisiform, which is pretty easy to find at the base of the hypothenar eminence. And last, and this one's a bit tricky, the hook of the hamate. You have to press deep, about 2 centimeters distal and 1 centimeter radial from the pisiform. A fracture here is super easy to miss on an x-ray, so your exam is key. And here's a quote that really hits home. A common pitfall is to skip testing pronation and supination. Please, whatever you do, don't skip this. Have the patient tuck their elbows in tight to their sides and turn their palms up and down. If they have pain or can't do it fully, that is a massive red flag for a DRUJ injury, even when the x-ray looks pristine. All right, let's get to the x-rays. And here's the challenge. We have to train our eyes to see beyond the obvious fracture line. The injuries we miss the most, they're not subtle fractures, they're dislocations. And that's all about looking at alignment and relationships. First up, on your AP view, you have to trace Galeazzi's 3 arcs. Think of it like this. You should be able to draw 3 smooth, unbroken curves along the carpal bones. If you see any kind of step-off, any break in one of those smooth arcs, something is wrong. That's your sign of a potential fracture or, more importantly, a ligament injury. Now, the lateral view.
I'm going to say it, this is probably the most important view for not missing a catastrophe. You are looking for collinearity. The radius, lunate, and capitate have to be stacked perfectly on top of each other. I like the analogy of apples stacked on a pole. The lunate should also look like a perfect half-moon cup holding the capitate. And finally, check that the distal radius and ulna are overlapping significantly. If they're not, you've got a DRUJ problem. And speaking of that lunate cup, if on that lateral view it looks like it's tipped forward like it's spilling its contents, that's the classic spilled teacup sign. And that is a huge deal. It means the lunate has fully dislocated, and it's a true orthopedic emergency. It can crush the median nerve and cause an acute carpal tunnel syndrome. Okay, let's jump back to the AP view for one more critical sign. You need to look for a gap between the scaphoid and the lunate. If that space is wider than 3 millimeters, that's what we call the Terry Thomas sign, named after the old British comedian with a big gap in his teeth. It means that critical scapholunate ligament has torn. Okay, so we've done the exam, we've looked at the x-rays, now let's put it all together and talk about how we manage some of these key injuries in the ED. When it comes to distal radius fractures, you have to know which way it's pointing. A dorsal injury, like the classic Colles fracture, gets reduced and splinted in flexion. But a volar injury, like a Smith's fracture, that's a completely different beast. It's way more unstable, and you have to reduce and immobilize it in extension. They're opposites. Getting this wrong is a big deal and can put the median nerve at risk. Here's your checklist for when to urgently call orthopedics. No hesitation. Any open fracture. Any sign of neurovascular compromise that doesn't get better with reduction. Acute carpal tunnel or compartment syndrome for sure. All fracture dislocations, that's paralunate, lunate, Barton's, they all need a call. And if you see the joint surface is stepped off by more than 2 millimeters, that's a direct line to future arthritis, so they need to be involved. All right, we're almost there. Let's finish up by talking about complications and the big takeaways. Because our job isn't done once the splint is on, right? We have to know what to watch for. So complications can be immediate, think acute carpal tunnel or compartment syndrome, but some are sneaky and show up much later. The classic example is an extensor pollicis longus, or EPL, tendon rupture. This can happen weeks, even months down the line, often after what looked like a pretty harmless fracture. On average, it happens about 7 weeks post-injury. This is why our discharge counseling is so important. We have to tell patients what to look out for. So here it is, your wrist injury checklist. It all comes back to having a system. Systematically palpate those 4 divots and 3 bumps. Always test pronation and supination. Scrutinize that lateral x-ray for the radius lunate capitate alignment. Trace Gilula's arcs. Recognize that volar fractures are unstable, and counsel every single patient on the red flags for compartment syndrome. This is how you avoid the pitfalls. So I'll leave you with this final thought. On your next shift, when you get that wrist x-ray back on a young patient after a foosh, and the report says negative, are you going to be confident that there isn't a serious ligament injury hiding there? Remember, a normal x-ray does not always mean a normal wrist. Your hands and your systematic approach, those are your most powerful tools. Don't get fooled.